Hello and welcome everybody. It's a pleasure to have everyone here on our third webinar on the webinar series. I'm here with the Professor Possover. I'm Henrique Abrão. There is Abhishek, who is our main speaker for today for a lecture on chronic pelvic pain and the neuropelveological point of view. Mikey is here also. We will introduce ourselves in a few moments, and we are waiting. Anna just arrived also. Mikey, if you want to start by you.
Yes, sure. I'm going to be super quick. Good afternoon and good evening and probably good morning to some. I'm Mikey Adamczyk. I'm a consultant in the UK, and welcome to the third series of our webinars.
Thank you very much. Anna?
Hi, I'm Anna Sierra. Welcome to this webinar. The subject today will be chronic pelvic pain, and we're going to listen to Dr. Abhishek, and he's going to give us a great presentation today.
Yes. I'm Dr. Henrique Abrão. I'm the Professor Possover's Fellow, and I'm very glad to be with this select group in this webinar series. It's been a pleasure to be co-hosting with them all of this. Abhishek?
Thank you, Enrique, and thank you to the eyes on board, and of course, Professor Possover for creating and incepting this group where we've worked together, and also we've grown to be very close friends. And I have the privilege today of speaking about a very difficult subject, which is chronic pelvic pain. And it's interesting because it goes way beyond endometriosis, which is not where we should stop diagnosing, and we should look beyond endometriosis in this case. So with that, I'm going to start my presentation.
Just 1 second. The professor, I think it's way beyond introductions, but Professor, would you like to say some words?
Come on, I'm the old grain man in the round. I don't think it's no need to present myself. No. Please go on, Abhishek. Good luck for your lecture. And just to remember, this education webinar are for the patient. So maybe just if we're patient, please don't go on your own medical history. But we will give answer at the end of the lecture of Abhishek for high-level question, but we will not go in single case in deep. Okay.
Yes, we have some introductional things to say. We decided this time at the end we'll open for discussion for everyone. We will conduct the discussions by the chat. So this time we changed the little bit the format. We'll change the discussions by the chat. So by the order of the questions, just send us by the chat, and we will talk the discussions by the chat. And everyone is free to make questions. And as the professor said, we won't be discussing cases. We'll be discussing questions about the theory, about doubts and everything, but not at all clinical cases. Now, Abhishek, if you would like to enlighten us with your talk, please.
Thank you. So, like I said, the topic for today is a very difficult one, and chronic pelvic pain. So to start with, since I'm an endometriosis surgeon and we're moving away from endometriosis and beyond endometriosis with this, we need to understand the relationship between pelvic pain and endometriosis in the first place. So if you look at these three slides, you would imagine the first person who has very subtle cystic kind of endometriosis in the peritoneum would be pain-free. The middle picture has pain scores of 3 out of 10 for 5 days in a month. And the one with the frozen pelvis with bilateral endometriomas and the rectal nodule can have pain 20 days a month with a score of 8 out of 10. But the reality is the patients may present this way, where the subtle disease can present with the most chronic kind of pain. Now, so we need to understand before moving forward that between endometriosis and pelvic pain, there is a complex relationship which is not entirely explained by the lesion. there's a minimal relationship between the extent or location of disease with pain symptoms. There's no consistent relationship when we look at inflammatory markers, nerve fiber density, where you have neoneurogenesis and increasing in the size of the nerves. And you also have pain that may recur following surgical excision without evidence of recurrent disease. Now, when we think of chronic pain, we have to think way beyond endometriosis. We have to consider adenomyosis, adhesions, chronic PID, fibroids, pelvic congestion, vascular entrapments, ovarian remnants, iatrogenic nerve injuries from surgeries or from deliveries or instrumental deliveries, and many kind of things. So when you start deep diving into these things, you see that there are tremendous papers out there that show the neuroimaging of pain, and it's a very complex pathway where you have your peripheral nervous system that goes into the spinal cord, which transmits to the brain. And you see this work that shows very different areas of the brain that react to different kind of pain stimuli, and that will direct the body's response to pain. So this is very daunting in itself, not only for a physician, but I'm sure for a patient as well to take on. When we look at the most important thing when I was starting my journey in neuropelveology, the most phenomenal story that still sticks with me to this day and stirred my interest in neuropelveology is when the professor explained this very simple concept so beautifully. So pain is not a pathology, it is information. And when you have, in this example, when you have sympathetic nerves of the pelvis, when there is pain from endometriosis of the uterosacral or from adenomyosis, you have an activation of the inferior hypogastric plexus, which induces a closure of the cervix, which makes the blood stay longer in the uterus, which leads to degradation of blood products, which gives you the brown or dark colored blood when the menstrual bleeding is past. Now, this is phenomenal because he said it in such a way that this is from a time when man evolved from primitive man, and there was a fight or flight reflex when they were being pursued by predators, and the female of the species would only menstruate once the danger had passed. So this is a flight or fight reflex that has kind of perpetuated through. And of course, we don't have any predators anymore, but pain is the stimulus which incites this reflex. Okay. Yeah. So when we come to talk about chronic pelvic pain, this is supposed to be the most complex condition, and every specialty in medicine is daunted by this, whether it be gynecology, urology, gastroenterology, neurology, orthopedics, musculoskeletal disease specialists, or even radiology. There's a consensus that a patient with chronic pelvic pain is the most difficult patient to treat. But when we understand chronic pain from a neuropelveology point of view, that is going to broaden our understanding of this most complex of conditions. So let's first cover some basics where we understand visceral pain versus somatic pain. And we'll use the professor's methodology to understand how we make the diagnosis in chronic pelvic pain. So visceral pain has vegetative symptoms as well, urinary urgency frequency, painful micturition, so painful passage of urine, pain while passing stools, suprapubic pain, abdominal pain, and cramps and chills. Somatic nerves, on the other hand, this is usually in the pelvis, which affects sacral plexus and other somatic nerves. The symptoms are more burning, tingling, electric kind of pain, so the nature of the pain. You also have some numbness or muscle weakness and sensitivities. And also there is urinary or bowel dysfunction. Now, the key to the diagnosis of chronic pelvic pain is the vulva and the vagina for our female patients. They're the first steps in the neuropelveological diagnosis for chronic pelvic pain. For example, a deep vaginal pain is usually incited by the irritation of the inferior hypogastric plexus, because that supplies the upper 1/3 of the vagina. And this can cause visceral pain and some vegetative symptoms. Whereas an anterior vulvodynia, which is pain in the vulva and the groin, is suggestive of genitofemoral nerve issues. And a pudendal nerve pathology, which is in the perineal area and that region, which is pain in the vulva and the surrounding perineum. In some cases, if it's in the lower third, is called Alcock's canal syndrome. And then you have sacral plexus pathology, which combines pudendal pain with non-gynecological pain, such as sciatica, gluteal pain, or back pain. So these patients may end up seeing an orthopedist for this kind of pain, but it is a neuropelveological diagnosis. Now, I know this can seem a little complex, so I'm going to go over this relevant to our topic and cover it in some more detail further on. So the first step of the neuropelveological algorithm is we have to figure out if the pain is visceral or somatic. So simplifying it down, visceral pain involves organs, somatic pain involves nerves. So when you have visceral pain, it's caused by organic pelvic conditions. Symptoms are vague. So the patient will present with vague, poorly localized pain, whereas with somatic pain, he or she will be able to take one finger and say, okay, it hurts here. So that is the primary difference. And also the vegetative symptoms usually will come in with visceral pain, such as malaise, chronic fatigue, dilatation of the pupils, salivary inhibition, and nausea, vomiting, etc. Now, we must always draw back to the professor's analogy of the light bulb. Where is the problem? Is it within the bulb? Is it within the wiring? Is it in the light box? Or is it in the power company? So the second step is determining the nerve pathways involved in pain relay. So somatic neuropathic pain is going to cause location in the skin. So the dermatome will show you which nerve pathways are involved. I think Dr. Anna, for whoever you had attended, had a beautiful presentation on the dermatome. So we're not going to spend too much time going on to that. And it is very important for doctors to adopt a neuropelveological way of thinking when we think about chronic pain. So the next step is to evaluate the level of the pain. Now we have to think not just of the light bulb analogy, but think of the nerve pathways in the body like a series of highways with multiple intersections. And this, I want you to have this photograph in your mind and use this to understand the next slide, which is the basis for every neuropelveological diagnosis in the pelvis. So the key factors for pain evaluation are the patient's history and digital palpation of the pelvic nerves, the lumbar plexus, sacral, and pudendal nerves. Now we have combination of different pain locations and dysfunctions, which help us determine the lesion. And for that, we will use this diagram, which is brilliant, and it will help you come to a diagnosis or help the neuropelveologist come to the diagnosis of most pain syndromes. I'll just explain it briefly. So what we have up here is the sciatic nerve, which you have L5, S1, S2 fibers from. The pudendal nerve here, which gets S2, 3, 4. You have your bladder here, which gets S2, 3, 4, and some fibers along the pelvic splanchnic nerve and from the pudendal nerve to the bladder as well. So what this means is when we look at a patient, for example, if they have just sciatic pain that is radiating down the leg, it is pelvic irritation, which is allodynia in the bottom and the dorsal face of the leg. If it is bilateral, it's probably a lumbar disc hernia, so we look higher up. Now, when you have S1 and L5, which is pain in the lower back, the buttock, the dorsal leg, and there is no groin pain or no pudendal or genital pain, and foot extension issues, so no in case of any neurogenic lesions, that is S1 plus L5. So those sacral nerve roots. And when you have S2 itself, if there's only a lesion of S2, there's medial leg, pudendal area, and motion difficulties in the toes. When you start to have some bladder involvement and retention or hyperactivity of the bladder, and you have pudendal pain without spreading, that's S3 and S4. And a pure pudendal neuralgia will be pain in all the pudendal areas with no radiation to the buttock or the leg, but can cause bladder or bowel dysfunction. This is a brilliant algorithm to have in the back of your mind when making any kind of diagnosis. And then using that, we establish a potential etiology. And most important to base on that is it's a combination of factors. We use the patient's history, our neuropelveological exam, and if needed, we have a pelvic neuro MRI that's done, and your adjuvant test depending on symptomatology, etc., like urodynamic studies, etc. And then we need to focus on pelvic tumors, varicosities, endometriosis, among other diagnoses. Now, one needs to be able to differentiate between neurogenic versus non-neurogenic lesions. So neurogenic lesions, there will be a reduction in nerve function, problems with locomotion, a hypoesthesia or an anesthesia of the area. So loss of sensation or decreased sensation, bladder retention, sexual dysfunction, and constipation, such as chronic constipation, not acute. And non-neurogenic lesions, the nerve function increases, which leads to a hypersensitivity or increased sensation of the area. There's increased sensitivity or an overactive bladder, symptoms mimicking IBS, or increased phantom pain. Now, the fifth step is to confirm and offer a therapy of the potential etiology. Now, on the examination, if the nerve is easily accessible by injection, such as the pudendal nerve or the sacral nerves, we can do a local block in the outpatient itself or under imaging guidance to confirm the diagnosis and then follow it up with either Botox or steroid. If the nerve is deep in the pelvis, a laparoscopic exploration with the required treatment, which is a nerve release, or the lion procedure, which is the implantation of a prosthesis, which I think Enrique will be touching upon in the upcoming webinars down the line. It is also very important, and I must say this to physicians who are watching, that these surgeries should be undertaken by someone who's trained in this procedure. It's a difficult surgery, but if it's not complete, it is very, very difficult to redo because of the fibrosis in those spaces can make a difficult surgery an almost absolute nightmare to undertake as a second surgery. Now, I'm going to spend some time talking about patient history because this is very important. Our main diagnostic tool is our ears, the ability to listen. So we must listen to the patient and spend a good 20, 30, or 40 minutes on anamnesis to understand the patient's history. And we need to understand time of onset, duration, severity of pain, understand the patterns of pain. All the while, we're using this information to form a mental roadmap to help aid our diagnosis down the line. Now, we need to know location and radiation of pain. So we need to know, of course, visceral pain will be vague and poorly localized, but somatic pain is either truncular, which is your sciatic, obturator femoral nerve, which are lower down in the pelvis, and your radicular, which is the lumbar and the sacral plexus. And of course, we know that it's a burning, tingling, allodynia kind of pain. It's more localized as well, the somatic pain. Now we need to understand risk factors or aggravating factors. So you ask the patient, what makes the pain worse? What makes the pain better? So for example, a pudendal neuralgia, the patient will have severe pain on sitting down, which is relieved by standing up or sitting on a toilet seat for a long time to alleviate the pressure on the nerve that is getting compressed. You have vascular entrapments, which can be aggravated by increasing the pressure in the pelvis, like by doing a Valsalva maneuver, or in case of secondary to pelvic surgeries, which leads to fibrosis and further vascular entrapment. And if there is cyclical sciatic pain, which is an isolated endometriosis of the sciatic nerve, or a cyclical radiculopathy, that is the infiltration into the sacral nerve roots, which are the root values for the sciatic nerve. Then we have the pelvic examination, which of course we have, I'm not going to go through the whole thing. We have the professor demonstrating how we check the temperature, the different dermatomes, Tinel sign, pins and needles in the distal distribution when an affected nerve is palpated. And a nerve block can be done to confirm the diagnosis. And in case sacral nerve roots are involved, we do that by the epidural injection or under imaging guidance. Now, it's very important to know that your patient examination begins from the minute she walks into your outpatient clinic. So we look for gait irregularities, pupillary dilatation. When you shake hands, you look for sweating and for the pelvic exam, it's very intimidating for some patients, especially when they have vulvodynia. It can be intimidating. So I like to explain the process to the patient as exactly what will be done so they feel comfortable and may explain what they may not be comfortable with, and then you proceed with the examination. Of course, in some cases, we have a neurological examination that's mandatory, which is the assessment of the sensory and motor systems. We look for muscle tone and power, hip adduction that chests the L3 and obturator nerves, knee extensions for the femoral nerve, ankle dorsiflexion, which is the bending of the ankle. We look for a foot drop, like in this case where she had a isolated sciatic nerve endometriosis, which caused a foot drop. And then you check the reflexes, patella, ankle, cremasteric reflex in men, and the patient walking in the Romberg's tests, among the others. So, and then as neuropelviologists, we should be doing our own ultrasound, of course, not just to look for endometriosis, but also look for pelvic varicosity. So if you look at the left ovary that we looked at, and then you turn your probe, you can see these big dilated blood vessels on the left side that are significant for pelvic congestion syndrome, and they need some kind of treatment. Now, we also have to mandatorily look at the ureters and the kidney to not miss any silent kidney loss. Like you see, this is from endometriosis, and you see an entrapment of the ureter leading to a hydronephrosis on that side. So to culminate what we've learned from this, I'm going to share a case example that I had the experience of dealing with. And she was a known case of pelvic endometriosis, operated before. In 2018, she had a bilateral fibril cystectomy. 2019 was operated for peritoneal deep endometriosis and had an excisional surgery, nerve-sparing excision of the left uterosacral and a bowel nodule, dense adhesiolysis, peritoneal excision of the left broad ligament. Left ovary showed a small endometriosis implant. A fulguration was done there. But she presented post-surgery with cyclical right sciatica, severe since 2019, no preoperative MRI available. And post-operative, we had 3 MRIs available made to us, which had reports of unremarkable. On the present date of cycle, she presented for repeat evaluation. So we had a specialist look at that, and she had this very cyclical right lower limb swelling, so increasing in the size. That's why we measure the diameter of the thighs when we look at our patient examination. And we had it reviewed by our expert radiologist, who said that there is edema of the sciatic, around the sciatic nerve, but the lumbar spine was normal, so it's not higher up. And there was slight wasting of the right piriformis muscle and denervation edema. So because of the loss of the nerve function, there was some swelling around the nerve. And the same thing was confirmed on the other sections. And of course, when we did the laparoscopic exploration, you can see this vein going right across the nerve, which caused the pain. So I think of half an hour through, and we have enough time for discussion. So I thank you for your patient listening, and we'll open up to discussion or any questions if there are some. Thank you.
Great. Great lecture.
Thank you. Thank you very much, Abhishek. I'm trying to unmute everyone here. Just 1 second. Participants. Yes. Mike, you should be able to.
Yay. Right. Abhi, lovely presentation as always. It took me back to level 2, actually, when we were doing it in Zurich together.
Yeah.
And the picture of the examination as well brought memories, good memories. It's a lovely presentation. Thank you very much. Let's have, if there's any questions that you have for us that you want to discuss, please put them down in the chat room, and we will pick them up as we go and try to answer them. Okay, the questions are coming up, so let's have a look. Nicholas Ferguson is saying hello from Portland. We've got Sarah is saying brilliant presentation, thank you. Many of us have endo and autoimmune condition like fibromyalgia. Do you differentiate between that and nerve endo? So how do you differentiate between, for example, fibromyalgia and nerve endometriosis, Abi?
Right. So I work with a rheumatologist who does look at musculoskeletal and rheumatoid diseases. So I do refer some patients to fibromyalgia usually presents with pain moving in certain places, whereas I think nerve disease will kind of give you a clue to the dermatome that's affected, and you would look to kind of work in a neuropelveological way to figure out the level of the lesion and have a working diagnosis, and then move forward to start confirming that diagnosis and treat. I think we'd love to hear Professor Possover's opinion on conditions like fibromyalgia and nerve issues.
Yeah, I would like to say something because that is a very, very important question. As of first, the pain in a fibromyalgia is not the same. Fibromyalgia, as the name said, is fibrotic and muscle pain. A muscle pain is not like a neuropathic pain. Neuropathic pain is a burning pain. For example, if the pain starts in the buttock, the pain will go down, eventually down to the feet. The fibromyalgia is more located, but what is very, very important with Enrique, Enrique is doing a review of all patients who have performed a surgery for vascular entrapment. That means irritation of pelvic nerves by enlarged vessel or atypical vessel. And obviously what we found is that patients with vascular entrapment have a very high incidence of autoimmune disease. And the autoimmune disease like Ehlers-Danlos syndrome, thyroiditis Hashimoto, even celiac, lactose intolerance are autoimmune disease. And these patients have a very, very high risk to have atypical vessel or enlarged vessel in the pelvis that induce a pressure and irritation of the nerve. Then the problem is not the fibromyalgia. The fibromyalgia is maybe the cause, but the problem is the irritation of nerve by vessel. So completely agree this question. We will come out with a paper probably in the coming 6 months to 1 year, exactly focus on this issue. That is very, very important.
Really good point. And I think maybe this brings us quite nicely to the second question that is actually about pelvic congestion. And the question is, what are the available treatment options for pelvic congestion? Anyone who wants to take it?
Maybe if you agree, I will give a comment of that.
Yeah, of course.
The problem is not the treatment. The problem is not the treatment, but to know what are we talking about. Because normally pelvic congestion syndrome are enlarged vessel in the middle of the pelvis. And then you have to find a cause in the middle of the pelvis, like an endometriosis, or maybe enlarged ovarian vessels. And then the treatment is to treat this enlarged vessel in the pelvis. And embolization is one possibility that really pretty work. But when we are talking from vascular entrapment, it's a pelvic congestion as well, but not in the middle of the pelvis, but at the lateral pelvic side wall. So the nerve compressed by the pelvic veins are not the same. So the diagnoses are not the same. So when we're talking from pelvic congestion syndrome, the first thing before treating is, what are we talking about? Vascular compression of somatic nerve, like the sciatic nerve, or of the pelvic plexus, the vegetative nerve in the middle of the pelvis. And the treatment will depend from that, which nerve are irritated and not which veins.
That's really good point, Professor. And in terms of, maybe you should just maybe catch up, speak a little bit about the options. So what would you do if you have, for example, a patient with with the clinical symptoms of vascular compression of a nerve, any nerve, let's say. We know the answer, but what would you do? What is the correct way of doing it, Professor?
The first point, we are not treating an MRI picture on sonography. So if suppose a patient have a pelvic congestion syndrome, but the pain are quite low, I would not do directly a surgery. But when I have a patient with a big vessel compressing, for example, the sciatic nerve, and the level of pain is 7 or more, then you have to do something. And then the treatment of choice is not to do something to the nerves, but to release the nerve. So when you have a compression of nerve by vessel, the surgery is a vascular surgery. And that show us that neuropelveology is not gynecology. So it's, in this case, vascular surgery. And it's tricky because you cannot put a stitch or a clip on the vessel and cut in between. No, you have to release the vein from the nerve, and then you have to close the vein and to cut the nerve. And for example, when we are talking from pelvic congestion syndrome, irritation of the vegetative nerve in the middle of the pelvis, embolization is really a good method. I would not do a surgery for that. But for example, you have enlargement of the pelvic side wall and you decide to remove the uterus, you will make the situation worse because the blood from the pelvis will not pass through the uterus, but through the lateral pelvic side wall vessels. The vein will become even bigger and the pain will even increase. So once again, the key is not directly always what is the treatment. The key is to have the right diagnosis. Which nerve, which location, and then we can talk what could be the cause. And of course, endometriosis is one cause, but that is the most seldom cause when we are really honest.
It's a really good point. And from experience, we had one or two scenarios where we were expecting actually to find endometriosis of sacral nerve roots, for example, and that was even looked like endometriosis on an MRI. But when we got there, there was a big vessel going across the nerves. So that needs to be coagulated and not clipped. Right.
Let me give you a proof, because for many years I made a publication of that and I was not able from the clinical point of view to make a difference. There is but a difference. When a patient has an endometriosis of the nerve, the endometriosis will not disappear overnight. So the patient will have pain overnight, and even worse pain during men's bleeding. When you have a vascular entrapment, the blood pressure will decrease overnight, and the patient will experience much less pain overnight. And some of them even wake up in the morning without pain. So if the pain decreases overnight, it's more likely a vascular entrapment. If the pain is the same overnight, it's more maybe an endometriosis.
Okay.
Also, right. I think the patients that I see the most with congestive vascular syndromes are the ones that have hyperlaxitude in the round ligaments of the uterus. So the uterus becomes retroverted and the blood flow couldn't go up, the venous couldn't return. So in these cases, or also with adenomyosis, that the weight of the uterus makes that the uterus go retroverted, sometimes we correct the position of the uterus and then we restore the blood flow, and that removes the pain.
That's good point. There's another question. Is it possible to have genitofemoral nerve compression that affects urination? Abi, do you want to take it?
Yeah, I suppose not isolated genitofemoral nerve, but if it's in combination with another nerve, like we go back to the image. So if it's in combination with the sacral nerve roots or the pudendal nerve, then you can have some bladder hypersensitivity or overactivity.
Okay, I'm trying to sort of catch up. There's a lot of questions coming through. Yeah. There's a question. Thank you for the presentation. I'm a surgical pathologist suffering from PG PGAD. I wanted to understand the basis for PGAD around clitoris with no pain, only arousal problems due to pudendal nerve entrapment. So I think this is more of a statement, unless I'm misreading it. This is quite a difficult question, actually. Can you?
What is PGAD?
That's what I'm trying.
Persistent genital arousal disorder.
Okay, so that is not a pathology, that is a symptom.
Yes, so
Yes.
Mhm.
wanted to understand the basis of PG around the clitoris and the pain. I must say this is a difficult question. So there's a question about visceral pain and somatic pain from endometriosis. Can a patient have both?
Yes, of course. It is very possible to have both. For example, your visceral pain can come from the endometriosis, but also it can create somatic pain if the endometriosis is compressing the sacral plexus, or even on the sciatic nerve, you will have a radiculopathy associated with that. So the somatic component will come from that.
Just let me give maybe a small clarification. So it's the problem is, if I understand well, is more or less an hypersexuality. So that is
Yes.
something what I see. That means it's not a lesion of the nerve, it's an irritation of the nerve. And I completely agree, because most of this situation is not due to a pudendal nerve entrapment, because pudendal nerve entrapment will induce pain, but not just in the clitoris, also in the perineal and the perianal. So if the problem is located in the clitoris, you have you have more or less three possibilities. One is the genital branch of the genitofemoral nerve. Secondly is the dorsal nerve of the clitoris, which is the ventral branch of the pudendal nerve, or you have an irritation inside the pelvic at the level of the sacral nerve root S3, S4, which are in charge of the clitoris. And that will be the key of the diagnosis to find which nerve is involved in this condition. That is the first step. And then to think what could be the cause for that.
Mhm. Thank you, Professor. There's a question about, first of all, thank you for the great presentation. Question: is it typical for nerve pain to move around to different areas of the thigh, hip, leg, etc.? So is it possible for, or is it typical for nerve pain to be moving around from different anatomy? Abi, Anna?
Yeah. Anyone?
It's may I answer this?
Yeah, go on.
I think it depends on the cause. Everything on neuropelveology depends on the cause, depends on the diagnosis, actually, sorry. And if your diagnosis is something very strict to one point, so something like really on S2 dermatomes with S2 symptoms, then probably it won't be typical. But for example, we see a lot of vascular entrapments. For example, on a vascular entrapment, you don't have a constant pressing on exactly one point of a nerve, as would endometriosis, for example, do. So, for example, it's not only vascular entrapment, but the vascular entrapment is one of the diseases that can give us this kind of migrating pain only in the places of this nerve is affected. But for example, sometimes the patient wakes up with a more increased pain in the back part of the leg. Then in the afternoon, this pain may be still there, but also goes further down to the leg, and this may be possible. But again, it's neuropelveology is it's very important for you to do the diagnosis, because the nerves, they can tell us exactly where the pain is coming from and what nerves are involved. So yeah, depending on the diagnosis, it's possible, but it's also something tricky, because it can gives us some different differential diagnosis if we don't do the correct dermatome and analysis of the pain.
I think you've really nicely summarized that, Enrique. Really good.
May I give just a comment? The question is also the answer is from my side also yes. You have to think. Suppose you have a pathology of the prenatal nerve, you will not sit the normal way on a chair. If you are not sitting normal way on a chair, at some point you will develop shoulder pain, you will develop headache, you will develop back pain. So because not because you have a pathology of the nerve of the shoulder, but because of the wrong position. And in visceral pain, it's exactly the same. When you have an irritation of the visceral nerve in the pelvis, at some point, the whole visceral nerve system from the whole body will be affected. And that's the reason why some patients with endometriosis mention shoulder pain even in the hand. And it's easy as a doctor to say, you're crazy because endometriosis of the hand don't exist. No, she's not crazy because irritation of the vegetative nerve system will even induce pain in the hand. And that is exactly what Rabbi Sheikh mentioned. When a patient is affected by endometriosis, very often the hand is cold and wet because the sympathetic nerve system of the hand are affected or irritated as well. It's a whole body disease.
There are some very good points. Okay, I'm just going to be moving slowly through the questions. There's another comment saying, wonderful talk, hi team. Now that there's some awareness around evaluations such as you describe, oftentimes patients coming to the office assuming that the nerve pain is automatically nerve pain automatically means endometriosis on the nerve and they need to have big surgeries to care for them. Can you discuss what would be some of the treatment options or algorithms you may go through before you jump to an invasive surgery? So I think this question really sort of summarizes everything that Abi has mentioned in his presentation today, that we don't just do those big operations. It's a lengthy process of taking a history. It's a process of examining the patients, making sure that we actually are confident enough that we know what the pathology of the nerve is. We, of course, use ultrasound scans, MRI scans, neurographs, you name it, to make sure that the diagnosis is correct. But we, at least myself, we don't just jump and do big surgeries. And it's, as Professor, maybe you can answer this, but there's a question, I think, when it comes to the algorithms. And the algorithms that we have, we don't have them, right? It's what we've learned from you, what we've learned from each other. But it's such a niche field of medicine that we just don't have them yet. I mean, what do you have any comments on that?
No, I completely agree with you. Many times some colleagues ask me for an algorithm. So you give even an app. You bring the symptom in the app, and on the end you have a diagnosis. No, I think neuropelveology is too much complicated for that. How many times the patient come in my office, I have a diagnosis in mind, I suppose, and over the discussion, I'm completely changing my opinion. No, I think even the surgery is too dangerous to use an algorithm to perform a surgery. My second comment is stop to talk so much about endometriosis of the sciatic nerve. I have the feeling that neuropelveology today is only endometriosis of the sciatic nerve. Endometriosis of the sciatic nerve is the most rare etiology for pathology of the pelvic nerve. It's extremely rare. And now I know I will be very impolite, but in my age, I give me the authorization to say something. On social media, I see a lot of video of endometriosis of the sciatic nerve. And very often I'm asking, where is the endometriosis? I don't see an endometriosis. So I have pain going down in my leg, you have endometriosis, it's an endometriosis of the sciatic nerve. No, that is not the way. And to bring an algorithm to people, to colleagues who maybe have no understanding of the diagnosis, but just want to do the surgery, that is not my medicine. Medicine is first a clear diagnosis. And neuropelveology is a first line, a clinical diagnosis and patient history. And algorithm, no, that is too easy.
Brilliant. Thank you. Does anyone else wants to pick up some questions? So maybe we can have a change of voice. I guess everyone is getting bored of my voice now. Abi, do you want to pick up a couple of questions and read them out?
Okay, you have a lovely voice. Don't sell yourself short. And so, how do you differentiate between pudendal neuralgia leading to persistent genital arousal disorder due to artificial entrapment of the pudendal nerve on MR neurography against actual entrapment? I think
Professor.
this would be directed to the professor.
Do you want to get an honest answer from me? This webinar are for patient and not for education of colleague.
Fair enough.
I guess that's fair enough. Some of those questions are quite difficult, but what we really wanted to design those webinars is really sort of to spread awareness about pathologies for patients. Okay, that was the whole idea of the webinar. So we do gotta apologize in advance if we're gonna skip some deeper clinical questions, because those questions can be quite difficult to answer in a couple of seconds on the spot. Right. Let's go to the next questions.
Yeah,
Abhishek,
that's a specialist the female patient go to, a patient with a history of endometriosis. This is a very difficult question. I mean, sorry, what is going on? If the diagnosis of endometriosis adenomyosis is already made, then I would assume an endometriosis specialist should be involved at the very least. But if there is a suspicion of nerve pain or a neuropelveological diagnosis has to be made, it should be someone who's trained in neuropelveology. Now, of course, there are very few people who have that kind of training to be able to make that diagnosis. And the purpose is more to create awareness that this is a diagnostic pathway that is very useful in addressing pelvic pain and not just getting laser focused on the diagnosis premeditated by your imaging, which is the endometriosis or the adenomyosis, and thinking more holistically about what is causing this patient's pain, because everybody's pain syndromes are different. Now, chronic pelvic pain, if you noticed in my webinar, was very focused on the diagnostic process and how the logical neuropelveological way of reaching that diagnosis is made. It is not really focused on treating the pathologies, and there are many modalities of treatment, and it would take a very long time to cover all of that. So we don't really advocate for making that, but more about spreading the awareness about neuropelveology so that residents in training, future gynecologists, current gynecologists start to add this into their armamentarium moving forward.
Thank you, Abi. Right.
May I jump to a question? I found it really interesting, and I think it's a very nice question. I'm reading it here. My question is there a possibility to suffer from pelvic nerve damage despite a normal MRI of a normal lumbosacral MRI with gadolinium? Thanks. And would someone like to answer?
Yes, you can. Because it's about the way that they interpret your MRI. If the radiologist that interprets the MRI, it's not like really into making diagnosis about the pelvic nerves, they won't do special sequences about the nerves. Whenever we do an MRI and we are suspecting a compression, we don't say to the radiologist, just check all the nerves in the pelvis and let's see what happens. We have to tell him, okay, I think she has a compression and S2 level on the right side. What do you think? So she makes a special imaging about that that specific site, and she compares and contrasts with the other side and see if there's a compression there and what can be the cause, or if only it's a neuritis. So the gadolinium really doesn't help with the nerves. That's the first thing. And the other thing, it depends on the radiologist who is interpreting them. I used to didn't get any good like images, or they were telling me that I was like crazy or something. And then I found someone that really is into the nerves, and then we started making some diagnosis and helping some patients. So yeah.
I completely agree with you, Anna. We had, looking at general sort of MRI protocols that we have for endometriosis, it's quite often that we won't be able to see sciatic endo, for example, or any pathology of the nerve. Just looking at a normal sort of MRI that we have for all the endometriosis patients. What we do have in London, we've got a specific clinician that also looks, we do neurography, a sort of MRI, which is just a different way of looking at the images that look specifically at the pelvic nerves. Okay, so that's something that we use. There are some sort of clues with normal MRIs, but we're talking about sort of big lesions that we can either pick it up of muscular atrophy on one side, etc. So there are certain tricks that we can sort of pick up that might lead us to doing a better scan. But if in doubt, at least in the practice where I practice, what we do is we would refer those patients for neurography MRI, if in doubt.
And I think it's very important to make the MRI outside from any hormonal treatment, because if the patient has a small endometrioma within the sciatic nerve, under hormonal treatment, you have a high risk to miss this cystic lesion. So better to stop the hormonal treatment some few weeks before you make the MRI. And at best, you know, if you see my back, I have 300 years of gynecology. In all these book, all the colleague gynecologists always mention, if you want to make the diagnosis, do it during the men's bleeding, because during men's, you will see much better the endometriosis. And if you want to make an MRI, it will be exactly the same, during, at best, even during the men's bleeding.
If you allow me to go further in this question, MRI is not always the answer, and we are talking here about neuropelveology. Neuropelveology are nerves, and what nerves transmit are informations that we can see. It's kind of electrical information, and the MRI also cannot see. So way more important than the MRI is the clinical examination and the anamnesis. For example, if the patient cannot do the dorsiflexion of the feet and your MRI doesn't tell you anything, but you have a straight diagnosis, the problem is, how will I indicate a possible surgery if that's the case with a normal MRI? Sometimes this can be tricky, but imagine there's a light cable. This is the professor most bright explaining way for us to understand. Imagine a light cable. The energy that passes through this light cable to lighten a bulb, we cannot see this. The MRI cannot see this. And if there's a problem in this process, and sometimes the MRI says absolutely no, there is nothing, but there is a problem. We can see that the bulb is not working and the diagnosis is correct. Sometimes we need to detach a little bit of our needs for the MRI and go for the clinical diagnosis if it's correctly done. But yeah, it's I think summarizing the answers of the five of us, yes, you can have a problem of the nerve without an alteration of the MRI.
There's a good question as well for whoever wants to take it, really. And the question is about diagnostic laparoscopy and checking of pelvic nerves if the MRI is clear. And I think this is going to be a solid answer from everyone. Not a good idea. Okay, especially the difficulty is that a lot of those nerves are so deep in the pelvis, that behind big vessels, dissecting those areas just for practice or just for if there's no clear indication from examination or radiology, is just not a good idea for anyone to do. I think we all agree on that, yeah? Okay.
Let's do a diagnosis first, and then you perform a surgery. You don't do surgeries to diagnose.
exactly. Right. I'm getting slightly lost with all the questions. There's a lot of it. I don't know if I've missed some or not. If anyone picks up a good question, please read it out loud. Regarding MRI, there's a significant difference between
I see just one very good question that somebody asked. I have a patient who came with lower pelvic pain and 200 cc residual post-void urine. Previously, she had a radiation to the colonic cancer 5 years behind. Is there may be any relation nerve damage due to the radiation? I think you can give the answer, but it's quite clear.
Yes.
Who wants to answer?
200 cc post-void residual is very severe post-void residue, and that is definitely nerve damage, can be induced from radiation. Radiation focuses radiation beams at a particular area, and the outcomes of that lead to fibrosis, which is notorious for causing nerve entrapment. So it is a very, very distinctive possibility. And when you have the damage of that nerve, the ability of the bladder to void completely is lost and compromised. So she probably is in a condition where she has to push to start emptying the bladder, and this patient will eventually require self-catheterization to avoid the neuropathic bladder that has resulted from this.
What was the residual? 250?
300.
200.
200.
300?
There's a question about MRIs. It's quite a nice question, actually. Is there a significant difference between 1T and 3T MRIs? Patients often don't know and are not able to choose the strength. So we're talking about 1T and 3T MRIs. It's a really good question, actually. In essence, T3 is much more focused. But I was just speaking to a radiologist today, for example, and for example, for endometriosis, she prefers 1.5T because for her practice, T3 it gives you too much details. When I look at images, I do prefer 3T because it's much clearer for me. But I think it really depends on the experience of the person reading it. Does anyone has any comments on it?
No.
They probably see more artifact on 3 Tesla than on 1.5. I would assume that's the reasoning. Yeah.
Good point.
Makes sense.
Okay. Right. What else do we have? Okay, so there's imaging in reality for patients. The question asked for the radiologists often comes from general practitioners and what they computer systems allows them to put on the prescription. So often before interpretation that Anna talked of ad hoc in what insurance companies allow / practice. I don't know if this is a question or a statement, really. Imaging in reality patients when too often only comes down to the service providers planning and event management. Okay, I think this is a bit of a statement.
That maybe not everybody has the opportunity to have someone with nerve training to look at their eye.
I think with MRI is more to exclude pathology than to confirm a pathology. So suppose you have an irritation of nerve by a large vessel or you have a small stitch on a nerve, probably you will not see anything on radiology. But radiology is mandatory at least to exclude a tumor on a nerve, a schwannoma of a nerve. And you cannot exclude a tumor of the nerve just clinically. You can say, okay, I have a lesion of the nerve. It's what we call a neurogenic lesion. There are some damage of the nerves. But if the patient first didn't get any previous surgery, you have only 2 diagnoses, is endometriose or schwannoma. So in this situation, you have to make an MRI. You cannot go on a laparoscopy by suspicion of endometriose and you found a schwannoma. The surgery is not the same.
Yes. And also sort of for upper lesions of the spine as well, right, at times. Okay, I think we're coming towards the end of the webinar. It's 1 hour.
Yes.
Yeah.
To to give everyone some informations, I saw some people asking about the recordings. All the webinars have been recorded, and they are all at the professor's YouTube channel. It's at YouTube. You just search for Mark Possover in the YouTube, and you will find all the webinars in full. What else?
Not aware from that. Okay.
Right. So I hope you all have a. By the way, if you do enjoy this webinars, and obviously please come to the next one. I believe it's on the 7th. Is that right?
Yes, 7th. Mikey will be talking about treatment modalities, where to go and when.
So thank you very much, everyone. I hope you all enjoy football tonight. For those of you watching, hopefully England wins. Hopefully, and I wish you all have a good evening. Bye for now.
Bye
Bye,
bye.
everyone.
Good
Thanks
evening,
everyone for
everyone.
joining.
Bye.
Allez les bleus.